Hello, I will talk about gender differences in cardiodiabetes outcome. People with diabetes have markedly increased cardiovascular risk, but the relative increase in the cardiovascular risk is larger in the women than men. Women with diabetes more often have diffuse coronary disease and microvascular dysfunction, present with atypical symptoms, and carry higher post-MI and long-term mortality compared with men. For the possible causes, there are some factors as a common like age, hypertension, total cholesterol, and low-density lipoprotein, which affect the men more than women. But history of smoking, diabetes, triglyceride, and high-density lipoprotein affect women more than the men. Also, there is some specific factors related to the reproductive endocrine disorders like polycystic ovary syndrome and menopause. Also, there is a pregnancy complication like gestational diabetes mellitus, pregnancy-induced hypertension, and preeclampsia. Modern cardiometabolic therapies benefit both sexes, but there are signal and subgroups analyses suggesting variation in magnitude of benefit and underrepresentation of women in many trials, so sex-specific data remain limited. Major guidelines now emphasize aggressive cardiovascular risk assessment in all people with diabetes and call for sex-aware care pathways. Female has increase in mortality and increase in treatment delays and increase in emergency responses time due to sex problems and gender. Sex like menarche, reproductive endocrine disorder, pregnancy complication, menopause, and cardiovascular presentation. Also the medical risk factors which impact women like diabetes. Also, some factors related to gender like socialization, personality trial, gender role, caring responsibilities, physico-social stress, interpersonal relationships, and bias in the medical treatment. The epidemiology shows the relative risk for the women with diabetes have a higher relative risk of coronary heart disease, stroke, cardiac death, and all-cause mortality compared with men who have diabetes. Estimated vary, some reports up to 1.3 to 1.5 times higher relative risk, and other reviews point up to 50% higher in cardiovascular disease mortality in women with type 2 diabetes mellitus. In post-myocardial infarction and revascularization outcome, diabetic women have higher in-hospital and long-term mortality after acute coronary syndromes and less frequently use of revascularization and guideline-directed secondary prevention. For heart failure phenotype, women with diabetes more commonly develop HFpEF, while men more often developed HFrEF. Diabetes increases risk of heart failure for both sexes. Heart failure more prevalent in women than in men. Reduction of the gender gap in heart failure outcomes, independent predictor of mortality in women, and less response to anti-diabetic drugs in women. So the problem is higher in women. As a pathophysiological differences in biologic and vascular differences, women more have endothelial dysfunction, microvascular disease, and diffuse atherosclerosis. Sex hormones like loss of estrogen after menopause modify insulin insensitivity, lipid, and inflammation and vascular. Risk factor patterns like diabetes amplify other cardiovascular risk factors. like hypertension, obesity, and dyslipidemia, and some of these confer greater incremental risk in women. Diagnostic and presentation issues, atypical presentation and symptoms, and less obvious ischemia lead to diagnostic delay in women, which can worsen the outcome because of her atypical presentation and symptoms. For the health system and psychosocial, under prescription of evidence-based therapies, later presentation, greater psychosocial burden like depression, caregiving roles, access barriers contribute to worse outcome. Atherosclerosis, women tend to have more diffuse microvascular disease, while men are often present with focal epicardial lesions. Hormonal influence like estrogen deficiency after menopause accelerate insulin resistance and endothelial dysfunction. The female has many problems like heart failure, inherited cardiac conditions, adult congenital heart defects, and cardio-oncology, heart rhythm disorder, non-invasive cardiovascular investigation, cardiac rehabilitation, and coronary artery disease, heart valve disease. All of these affect the female and affect for the outcome of the diseases. The clinical presentation of the women most of the time present by atypical symptoms. Women with diabetes and ischemia often present with atypical chest pain, dyspnea, fatigue, which leading for underdiagnosis. Also, in heart failure, women with diabetes are more likely to develop heart failure, preserved ejection fraction. Heart failure this lead to less management. For the outcomes after major event like acute coronary syndrome, show higher short and long-term mortality in women and worse outcome after revascularization due to endothelial dysfunction. Stroke, diabetic women have disproportionate higher risk of ischemic stroke than men. Peripheral artery disease show female often present later with worsened limb outcomes. The worst outcome for women in acute myocardial infarction show more comorbidity, less access to intervention, different response to antiplatelet, less invasive procedure, revascularization therapy, and present by atypical and delay presentation. The cardiovascular disease risk factors control and impact the difference between female and male in the smoking, hypertension, obesity, glucose control, atherogenic dyslipidemia, and inflammation. But in microvascular, the female more than male, we show like nephropathy more than the male. Also, in death and microvascular disease, the relative risk in female more than the male. Treatment gaps. Underutilization. Women are less likely to receive evidence-based therapies. Statins, ACE inhibitor, sodium glucose transport inhibitors, glucagon-like peptide-1 receptor agonist, and glycemic control. Some data suggest women achieve less aggressive glycemic targets. Also, in clinical trials, women are underrepresented in cardiometabolic outcome trials, which leading to knowledge gaps. For psychosocial and behavioral factors, female more prevalent to depression among diabetic patients, linked to worse cardiovascular outcome. Also, for hair adherence, women may face socioeconomic barriers impacting adherence to medication and lifestyle challenges. In treatment, what works and what are the 6 differences? Risk factor control, intensive control of blood pressure, low density lipoprotein, cholesterol, smoking cessation, and glycemia are foundational guidelines to recommend aggressive risk-based approaches in diabetes. For sodium glucose transport inhibitors, strong evidence for heart failure and renal benefits across sexes. Most meta-analyses show benefit in men and women, though some pooled analyses suggesting a magnitude can differ, and women have been unrepresented in. For glucagon-like peptide-1 receptor agonists, reduce MACE and mortality in many trials. Meta-analyses show overall benefit and subgroups analyses are inconsistent. More research is needed to precise specific sex defect size. For revascularization and secondary prevention, women with diabetes often receive less invasive management and fewer guidelines therapies, so closing this care gap is crucial. For the practice pointers, treat the diabetes in patients and women as high-risk cardiovascular state. Consider earlier and more aggressive cardiovascular risk stratification like lipids, blood pressure, albuminuria, ECG changes, and ischemia testing when clinically indicated. Screen for atypical ischemic symptoms and microvascular disease. Low threshold for functional testing or cardiology referral when symptoms are ambiguous. Prescribe evidence-based cardioprotective drugs regardless of sex. Ensure equitable use of statin, ACE inhibitor, ARBs, sodium glucose transport inhibitor, glucagon-like peptide-1 receptor agonist, and antiplatelet therapy when indicated. Track and close treatment gaps. Address social and psychosocial barriers like depression, adherence, and access, which affect women and worsen outcome. Include sex-stratified data collection in registrars and trial you can run or use to improve future evidence. As a summary, sex difference in rate of type 2 diabetes and associated cardiovascular across the lifespan. Female has higher rates of type 2 diabetes in youth, while men have higher prevalence in midlife. In the absence of diabetes, cardiovascular disease rates are higher in men than women. Diabetes diminishes this difference, and women with type 2 diabetes have a 25 to 50% greater excess risk of cardiovascular event versus men. For the potential mechanism of for sex difference and the impact of type 2 diabetes on cardiovascular risk include biological and physiological factors and disparities in disease management between sex. Sex-specific efficacy on medication for type 2 diabetes may exist. The few studies that have investigated this show varying sex-specific outcomes of different agents on glycemic and cardiovascular outcome. In terms of cardiovascular risk, there is a relative under-treatment of women versus men, which may narrow at older age. Recent changes in clinical system have shown promise to reducing disparities in cardiovascular treatment. Women with diabetes carry a disproportionate higher relative cardiovascular risk compared to men. They tend to present later with more atypical symptoms, microvascular disease, and worse outcome after the acute coronary syndrome, heart failure, or stroke. Treatment gaps and underrepresentation in trial exacerbate disparities.